Okay, we're having a question and answer exam review using the blueprint that was posted for the final exam for the maternity course. So, questions?
Mm-hmm. So from high-risk newborn, preterm can be, so low birth weight, very low birth weight, and extremely low birth weight are just weights of preterm infants. Low birth weight can be a weight of a term infant.
What is the terminology that we use for a term infant that's below the 10th percentile?
Gestational age. Small for gestational.
Small for gestational age.
Okay, so don't use the term low birth weight for a term baby who's small.
Next question.
I have a question. When we're doing newborn assessments, and there are things like birthmarks and things like that, those are abnormal but expected.
Okay. So the terminology used for that is variations of normal. Okay, that means that yes, it's something that's there, and that it's not something that would need to be taken care of immediately, but it's something you have to document.
I have one from diabetes. I wrote, or like from 27. And it has to do with diabetes. In the text, there is like two different blood glucose levels for fasting and non-fasting. Like it gave two different values. So I just wanted to clarify what the values were for the glucose challenge test and the oral glucose challenge test. The oral glucose. OGTT.
Right.
What the values were for fasting and non-fasting for those two. Like low end and high end.
So you're going to use your book.
Wait,
so you're going to find out what because usually they don't do a non-fasting as part of the general checking of a mom. Okay. If they get a random, that's called a non-fasting, a random glucose, they would treat that with a grain of salt until they did the
glucose
the glucose challenge test, or the glucose tolerance test.
It said at the low end, or the above 95.
Okay.
But then another spot.
In the GTT,
I haven't seen it. Okay.
Yeah.
It says. So the cutoff for just
give me the page, please, so that everybody
page
can.
554.
Thank you.
It says that the cutoff is 130 to 135, but then down here it says that it's 95.
130 to 135 is not a fasting.
No, I know. I'm saying for like if they're over this is how they would diagnose. But then down here it says that 95, anything above 95 for a fasting.
That's anything above 95 is fine. It's not a diagnostic.
No, they're saying if it's above 95 and it's fasting, then they're likely to have gestational.
No, that's not correct.
Okay, so what should I do?
Well, it doesn't sound like that's what should be understood in that paragraph, is what I'm saying.
From my understanding, there's a challenge test, which is no fasting. If you fail that, then you go on to the GTT, tolerance test, which has the fasting.
The challenge test is where they don't draw it first, is what that's saying, right?
Yeah.
That's correct.
Yeah.
So you get a load, it's a lower load of what? 50 grams? And then if that is above 135, which is only a 1 hour GTT, okay, or 1 hour oral challenge, then you go into the 3 hour, which has a higher gram, which is what? 100.
You said 135.
And
the book says 140.
135 to 140 is fine.
So if they have above 135,
If that is a question on the exam, it's going to be way out of whack. Yeah, 5 points on a glucose level is not very much. So there's a difference between a 1 hour glucose screen and a 3 hour glucose challenge test or glucose tolerance test. That's correct.
So the challenge test is what they do first, it's the 1 hour, and then the tolerance test is what they do later, the value
3 hours, right. And the screening is the 1 hour. Thank you for asking, because that's a good differential. Next question.
I have one.
Okay.
On page 344.
344.
It gives you a safety alert box of the nurse's response to non-reassuring fetal heart rate patterns.
Absolutely.
And like, this is something that we've discussed in class before. It's stop the oxytocin, reposition, and on here it says the third thing you do is increase the IV fluids and then you do oxygen. Is that right? Because I thought we discussed in class that it was stop oxytocin, reposition, oxygen, and then increase fluids.
That was what we discussed yesterday about that whole, what do you do first? Start oxygen or IV fluids?
Wait, what page is that, Becca?
344.
And the issue is that you need to deliver the oxygen, and it takes time to get the oxygen to the fetus because you're trying to get the oxygen to the fetus. How do you deliver the oxygen to the fetus once a mom starts breathing in?
Circulation.
Right. So circulation would be the appropriate thing to get going first, then oxygen.
Okay, so circulation would come before oxygen.
So that would mean IV infusion before oxygen. I had a question that was like, so there was something I read, it was like, patient has, I wrote it down right here. I can't tell you what page number it was on, but I wrote it down when I was studying. And I put suspected prolapsed cord, which they said was, the nurse noticed it by variable decelerations following her membrane rupture. And then it said, what is a prior reaction? And it said, basically that you would do a vaginal exam first. It was like, A is vaginal exam, B is IV infusion, C is oxygen and something else, and I can't remember what D was.
That's correct. Because
I thought you weren't supposed to.
Wait, listen. We're talking about a ruptured membrane that is not artificial rupture membranes. It's spontaneous rupture membranes, correct? And so you need to find out where the cord is. The only way to find out where the cord is to do a vaginal exam. If you suspect prolapse, which you would if they were having variable D cells, right?
What was that order? That vaginal exam?
And then it was, it didn't tell me the order, it just asked what the priority action was, and so the priority action was to do a vaginal exam.
What's important about that vaginal exam if you feel the cord?
You don't touch it.
Tell us.
You push the infant up.
Well,
to get it off the cord.
Well, I don't want y'all using the terminology push the infant up because you're not pushing anything back.
Relocate the infant.
No, you're
Put them on the Trendelenburg.
That's one of the things you do. But you need to provide counter pressure for the cord, okay? To keep the cord off of where the presenting part is pushing against the cervix. You do that constantly.
Wait, sorry, repeat.
Can you repeat it? Yeah.
So you say that, put counter pressure.
Constantly. In the meantime, what do you have to do in the meantime, even before repositioning, because you don't want to stay there for forever? Call for help.
Ashley Blaze, I'm giving you an SBAR report on my patient.
No, you're going to do more than that. Call for help. What are you going to say when you call for help?
Cord compression.
Not cord compression.
We have a prolapsed cord stat.
Thank you. because the words prolapsed cord tells them they're going to have to get the operating room up. They're going to have to make sure the OB is notified and anesthesia is notified. So the words need to be more than just, I'm needing help in here. So in this case, which is one of the labor emergencies, you would say, I have a prolapsed cord, and then you'll have everybody there.
I have a question that's not specifically related to content, but something I think that I've been having trouble with is like on your blueprint, it says like infertility and fetal development, which is 3 questions.
Right.
How should I differ? I mean, because they're very different, but they're very long chapters. Do you have suggestions on what I should do to target?
Is there something specific that we need to be
Focusing on?
No. What you need to focus on is what would a generalist nurse need to know about these topics. About gestational development, particularly early, and about infertility and some of the knowledge that a nurse generalist would have about infertility.
So for infertility, I reviewed a lot of the factors. Was there anything else that, because I didn't find anything in the chapter.
What about the treatments?
About the treatments, so knowing all the treatments, the different IVF.
Being able to recall information about them.
Okay.
Because it has to be in context of what you would teach. Any other questions?
I have questions anytime.
Pain management for both the mother and the baby. How detailed do you want us to know? Do you want us just to know acupressure, acupuncture, aromatherapy, counterpressures, or?
I like all those things that you know them. What else?
Hydrotherapy.
What else for the baby? Because you mentioned infant pain management.
Sound, suckling,
swaddling, no nutrients,
those are very good.
Nutrition.
It's a
14.
huge issue in
I
pregnancy.
Like
But a nurse generalist would be able to give really good teaching about nutritional sources and about nutritional supplements and about dietary modifications for different beliefs and practices.
That was my deal, because now they're saying no supplementation, or try to limit it, whereas before that's what they wanted. And so trying to teach people about the foods they can get it from is, whereas everybody says, well, can I just take my prenatal? Well, they're not wanting that. It's like vitamin A, toxicity.
Is that in the book?
Yes, about the vitamin, about the supplemental.
Are they talking about nutritional supplements like you get at Walgreens, or are they talking about specific things like folic acid and?
It says multivitamins due to vitamin A toxicity and the folic acid.
But multivitamins are different than prenatal vitamins.
Well, are you meaning you're going to supplement, for a patient who's lactose intolerant, you're going to supplement beans or green leafy vegetables or calcium, things like that?
Yes.
Okay. What about?
And what helps with absorption?
Calcium.
Magnesium for calcium. And then for folic acid, you need OJ. No, that's iron. Iron is OJ.
Vitamin D.
But there's
calcium.
folic acid in OJ and fortified cereal.
Hey, we got another question.
For health maintenance during pregnancy for different beliefs.
Yes.
Are we going to need to know specifics, for Hispanic families or American Indian families. There's just a lot.
So what do you think?
I don't think so because we didn't. Really talk
What's
about
our
it.
cultural?
Blueprint.
What is? Yes, you did.
I know we discussed
Your
hot and
first
cold,
class was on cultural variations.
Culture's not on the
Oh,
blueprint.
don't assume.
But it can
ask,
be
right?
it can be internalized in any item.
Because you
Always
can
ask
generalize it and say, oh, they're Native American, but you don't know if they practice or believe to the Native American philosophies unless you ask.
And what
Can you give me an example?
culture would we see more than anything else in Central
Just area
Texas?
Hispanic.
And you can find that on page 246. Different things to ask about cultural assessments.
And here anymore, Vietnamese.
Wait, can you give me an example of how culture would be interrelated to another aspect of content?
Nutrition.
Well, yeah.
Like we had in our pregnancy thing.
Hot and cold
Pregnancy,
philosophy.
hot and cold periods. And
Yin and yang, hot and cold.
and how families prepare for the child. Sometimes they don't even bring like cribs or baby clothes home before the baby's born.
I know, but what does that have to do with preeclampsia or like preterm labor? I'm like,
No.
I need to understand how it
It's
fits
just cultural.
in there.
It's about family-centered
Like
care.
subjective things.
Family-centered care is about the family's situation being primary.
Look at this. If you're going into a room, let's say you have a young Hispanic woman. You're going in with a male nurse. Is she going to be comfortable?
Maybe. Depends.
Think about no.
No, she's not comfortable. It would have been better if you would have said like Middle Eastern. That would have been more.
Well, Hispanics have the same about modesty, especially for young women.
Not modern day. Now,
But it's still part of the culture.
Okay. So just.
Was all the contraception stuff?
That's in it's in the children's.
It's back over
It's in
the
the section.
It's in the
Did
D's.
we get a lecture on contraceptives or
No, you got a topic list on it, which means you're responsible for it.
It's in the peak section in the 600.
Like 224, 248.
what about the intimate partner violence?
That
That was special
threaded.
topic.
That was threaded throughout
Yeah.
all of the lectures as it came up, having to do with preterm labor, having to do with assessments that you do during pregnancy because of the increased risk during pregnancy of escalated intimate partner violence. We talked about it in bleeding, talking about abruption and so it was interspersed throughout all of the lectures.
I found some. Sorry, did you want to ask for anything else?
Yes.
Okay.
Is there any certain scoring systems that I should be very familiar with?
All the ones that we covered.
All of them.
Yes.
Biophysical profile.
All of them?
Just all of them. I should know how to score.
APGAR.
Wait, can you tell me what those are again?
Biophysical profile. APGAR.
The what?
Bishop.
Readiness for delivery.
Bishops.
Bishops.
That's her induction. Can you think of any other ones?
That would be good for you to go back through your notes and think of.
I have so many notes.
I know.
So many pages. So many notes.
I have notes on what they are and what's good and what's bad. I don't have notes on how to calculate.
Second that. Question. Or did you go? Okay.
Well, Becca was
Okay,
getting
yeah,
ready to ask.
Sorry. Variations in the passenger.
Uh-huh.
How in detail are we gonna have to be about that? Because there's a lot of variations of
There
passenger.
is.
Yeah. Yeah, there is.
Yeah. So you have to be able to put it into context of an exam item.
So
Wait, what?
can I have an example of that?
No.
No?
Like an untest related example.
Because
an example.
Because there's all of these like LOA, Exactly. Like,
when they're presenting posterior, what are they going to present? Lots of back pain. How are you going to counteract that back pain?
Okay, so next.
And or
Me.
Next.
My turn.
Okay.
I've been waiting.
Yes, ma'am.
I was wondering, because I saw some variations between the book and my notes, and evolved questions asking about when the fetal heart rate starts beating, if mom wants to know. And one said 6 and one said 8. So I want to know when you
The
say. The
difference is when can you visualize it on sono and when can you hear it on Doppler.
But on Doppler, you can't hear it at 6 weeks because you need to train.
That's right. Exactly. Only by ultrasound.
So that's 8.
So you need to find out from your book when you can pick it up on a Doppler and hear it.
Visuals 8 weeks?
Post LNP.
Any other things about fetal development? Like, should I be knowing, like, these specific things come from the ectoderm, and these specific things come from the endoderm, and at 14 weeks and 3 days, this happens?
What's more important than that specificity of...
That is not important for nursing.
No, what is more important than knowing what grows from where?
Nutrition, the amount of
standard Doppler is 10 to 12 weeks.
Doppler 10 to 12 weeks.
What affects the fetal development during the different stages?
So you said 10 to 20? Or what did you just say?
I said something completely different.
Can you say it again, please?
Yeah. That what's important is not when what develops according to what tissue type. What's more important is that you know what would affect neurodevelopment, what would affect kidney development, what would affect musculoskeletal development according to fetal. It doesn't have to be an exact time period, but some of the major,
at certain times,
exactly,
environmental factors at certain times.
And just as a hint, because Ms. Hunt does give hints, what's the key in a pregestational diabetic? Pregestational diabetic.
You need to control the glucose levels.
Preconception.
That's right.
Oh, counts.
Well, the biggest thing is
controlling it
preconception.
Early first trimester, because the most critical fetal organs develop in the first trimester.
But what is the thing that is causing the defects in a pregestational?
The fetus has hyperglycemia, so its body is focused on processing the glucose rather than building the baby.
And it doesn't have the pancreatic maturity to produce the insulin that it needs. So it's hyperinsulinemia of the fetus, which sidetracks the development of the fetus. Make sense? Why does that not apply for a gestational diabetic?
Because they don't develop until after the first trimester.
That's cool. It's a threshold thing. Next question.
Other than infertility, like for like the treatments, but also like today we came across one of the things in there that was like the patient wanted to know like would abortion cause infertility, but anywhere in the text it didn't specifically say that it would cause infertility. Is that something that I should be concerned about? Like studying, trying to figure out what other things can cause infertility besides other just normal factors that cause infertility? Does that make sense?
The infertility factors that you have in the book are what are appropriate.
And alpha fetal protein. Can you like re-explain that to me?
No, you're going to explain to me what you understand about it.
I understand that it's
indicator
prenatal
for term labor.
Chromosomal
No.
abnormality.
And you said something else that's important that everybody needs to know.
Take mom's blood and you pull the baby's DNA, traces of the DNA out of the blood, and you're testing that.
That's fetal DNA. That's not alpha fetal
That's
protein.
fetal alpha fetal protein, but alpha fetal
Maternal alpha fetal
protein is taking mom's blood and checking baby.
Checking to see if there are any abnormal fetal cells.
And you need to have appropriate weight and gestational age, or it could alter the results.
So what you have to do is make sure that the lab is providing those for you. So the key to the nurse's role is to know what gestational age is appropriate for drawing a maternal alpha fetal protein. And then what it says, and realizing that the maternal alpha fetal protein is not diagnostic. What is it?
It's like a good
Yes,
screen. Yeah.
it's screening. What is diagnostic?
Fetal alpha fetal protein.
No. Amniocentesis. Because that's direct fetal DNA. So it's the difference between direct and indirect. Next.
Infection. Are we thinking about infection postpartum or infection
Yes.
term or infection that can occur anytime?
Yes. Anytime.
But there's only
Pregnancy.
There's 6 questions, but that's bleeding, infection, preterm labor, and preeclampsia.
Right.
But there's so many types of infections.
Exactly.
What do you mean?
Basic signs and symptoms of infection during pregnancy.
Well,
I know that
your
part.
thing says infection and preterm labor.
Oh, those are 2 different categories.
Yeah. Like infertility and fetal development.
Yes.
Oh, psychosocial.
Yes.
I had a really, I don't know. I'm psychosocial. I said psychosocial adaptation to pregnancy, but in adaptation to pregnancy, I had a really hard time finding stuff other than the psychosocial assessment and like the normal, changes where she's.
That's what we're talking about. That's exactly. Give us the page number, please, so everybody knows about it.
Well, there's like the maternal role transition, which is page 239. And then there's the psychosocial assessment, which is somewhere over here. I'll find it, don't worry.
While she looks for it, any other questions?
No, I have lots of questions. Don't you move. It's here's the psychosocial concerns, and that's page 247.
Okay.
Okay. Family issues, does that tie back into like the intimate family partner violence, or is that like a whole other set of family issues?
What do you think?
I don't know.
This is like the stuff on the last test.
Okay, Rebecca's giving a couple of good terms.
So communication and like family roles.
And what else?
Helping out mom after.
Wes?
There was the siblings adaptation, the father, the grandparents, how they
Called intergenerational.
You got a picture of that?
No, I just what's his name?
Next.
Should I be thinking about things that weren't on previous exams or things that were on previous exams?
No. Like we apparently didn't do very well in Bishop score on test 1 and 2. Should we anticipate seeing that again?
Yeah, that's what I'm trying to figure out in my brain.
I haven't decided.
What do you mean?
Is there any calculation questions on this test?
Yes.
How many?
I don't know.
What do you mean?
You wrote it. How do you not know?
Let me see if I got more coffee in a second here, yeah. Carol's brain is quickly dying.
Questions?
Prenatal care management, is that just chapter 3, like the adaptations to pregnancy, or is there a chapter on prenatal management?
It's spread all throughout.
Yeah, that's exactly
there's
right.
Some,
High risk,
there's some high risk, there's some. It's all
It's
spread
throughout
out.
the chapters. Because prenatal care is about helping to guide both maternal and fetal health through the whole journey of pregnancy.
Well, that's the whole book.
I know. That's the whole course. This is a final for the course.
I know, just trying to review targeted things.
I know.
And not read the whole 30 chapters. So I'll do that if you want me to.
I don't want
Just
to.
go through and what you we've gone on the exams. What
Yeah.
threw you for a loop.
Yeah.
Focus on that.
I went through and I took all the evolved tests and wrote my scores just to see, and I made 90s on almost all of them, except there's like 3, 4 that I made like 80 or 75. So I went back and I read those chapters, and the new stuff really is what I'm focusing on because I haven't been tested over that, so I can't evaluate myself on that. I'm trying to just figure out if there's anything else I should. Yeah.
I just have to read more, so.
Any other application questions that we could practice? Because Evolve only gives us so many.
Yeah.
And I've gone through all the quizzes on HEI.
Well, you also have all of the case studies that we've done in the last 2 days. And you saw how questions are brought up, like what are some of the important things that you need to know before you do something else. That's about priority and setting.
Indication of where you kind of.
I haven't been able to fill in all of the case studies, so no, you don't have a roadmap to the final.
Okay? So the case studies are not a roadmap?
No, but they're a lot of the key information, or I wouldn't have presented.
Sorry. Okay.
Again, remember that what I'm interested in is that you know how, as a nurse generalist, to respond to ordinary nursing level and not social level of questions about risk management, risk identification, risk management, those red flag things, and whatever's normal about pregnancy, okay? So we spent a whole lot of time talking about normal pregnancy. And then we went into overdrive in October and in November to put it into context of high risk. And so the high risk stuff was quick because you had half of a semester of normal.
I know something that I want to ask. It's about mental health.
Yes.
Because we didn't go over it in depth, you know, in lecture. So I was wondering, do you have anything that you, not like indicating for the exam, but important things about mental health that apply to OB as a nurse generalist?
Well,
like
the
certain
biggest
diagnoses or.
Well, no, I'm not going to go to certain diagnoses. The big thing is psychosocial adjustment. Okay. and knowing when you need a referral. And that comes out of both your psych course and your maternity course. Because you know that there are some risk factors that people bring into pregnancy that affect the pregnancy.
So in the OB sense, you need a referral when the mother can no longer provide care or she's having psychosis.
Exactly.
Or when she's a danger to herself or others.
That's exactly right. And the others, the key others that she's endangered to is what? The fetus or baby. Yeah.
Goblins.
Goblin.
Demon children.
The little snotty germ factory kind of stuff.
So what else?
Everything. Any other assessment tools? Because I really got strung up on that last question on the test because I read assess this and I hadn't read about, postpartum assessment tools, I guess because it wasn't like really brought to my attention in lecture. So, that didn't seem like a real thing to me at the time. So
there's a ton of real tools.
So is there some other
that
assessment
nurse generalists depend on when they need to have an objective measurement of things. The mental health ones are just one. Another one is newborn's cries scales, newborn pain assessments, and just realizing that there are appropriate. What's another scale that we talked about in the newborn? Another scale about assessment. Huge one.
Talk about the fetal age.
Oh, prematurity.
That thing.
So gestational age assessment, Ballard, that's a tool. What's another one? What's another tool?
PIP. Huh? Premature infants pain. Something.
Yeah, the NIPS and the cries and the what's the third one for newborn pain assessment? What about a newborn that's withdrawing from intrauterine opioid exposure?
The neonatal abstinence care scoring system.
NAS system. NAS. It's up to the nurse to initiate that.
I have a question about Ballard scores.
Yes, sir.
Are you going to expect us to see an assessment finding and determine gestational age off of that?
What do you think?
I don't think so because you didn't expect that on the last test.
So what do you think is important to know about the gestational assessment tool?
I think we should know what normal is and when to ask for help when it's not.
No, think about what is a gestational age assessment tool validating.
But the fact that they're not at their gestational age lower and they're more at risk.
What are you assessing though?
Assessing the infant maturity.
Physiological appearance and behavioral.
So physical appearance and behavioral neuro.
Tell you about physiological.
So right, but it's the physical and the neuro. There are two pieces to it. Physical and neuro. For you to know about that, Ballard, I don't think you need to know the, breakdown of how many points for what. But you do need to know more than, a Ballard measures gestational age. Okay?
And as far as contraceptives go, should we be knowing like medication names or classes?
Classes for sure, but not necessarily medication. Classes of contraception.
That's like diaphragm, oral, barriers, condoms, IUD. Yeah, that's what I'm saying. Progesterone,
progestin only, combined.
Okay, so who's contraindicated to have what?
That's what you need to know.
Any of the oral medications,
any of the
over 30 years
hormone-based.
old, hormone-based.
Hormone-based.
30 years old, smokers. I think the book says 35, but if you read your packets, they say 30.
It's chapter 31, page 665-ish.
What would cause contraception to fail?
Don't take it on time. Drinking, antibiotics.
Antibiotics. Drinking.
On Christmas.
Not taking it
And taking antibiotics at the same time. At a Christmas party. I am speaking from experience. Welcome to the world, Carson. Nice to meet you.
So these are all just very good healthcare principles.
Which one is hypertension?
Yeah, just put other medications or locations.
Hypertensive medications.
So that's what I'm thinking. Okay, so this is my question to you. And please, I'm trying not to go crazy in the next 10 minutes. So, like, when I'm studying, so should I be studying, like, contraceptives, contraindications, smoking, age, medications? Or should I be studying contraceptives, this, and this one, contraindications, this antibiotic, and this medication, and this specific age? You know, I'm trying to figure out.
I think you're going to read too much into every single item.
Well, I'm trying not to.
Okay. So I think you need to consider.
If someone's on oral contraceptives, why shouldn't they take it? When shouldn't they take it? And just if their age is over, if they're on other medications.
Okay.
So when somebody is breastfeeding,
yes,
they don't need to take. They're not supposed to. If it's estrogen based.
No contraceptives.
No, that's
not. No oral contraceptives.
You need to read on your nutrition chapter what is the guideline for contraceptive use in breastfeeding.
I know you're supposed to continue, but you're not supposed to continue if it's a certain kind.
That's why you have to cook it up.
I think it's estrogen.
Cook it up.
Which I didn't know that there was different types.
Estrogen and progesterone. And then you have IUDs and implants. That's it.
Not just an estrogen.
On feeding, I feel like I have questions for newborn feeding.
Mm-hmm. So what are assessments you need to do when the baby's breastfeeding for the baby?
Good
Sucking.
Suck, swallow, and what coordination?
Breathe.
Suck, swallow, breathe. What's the other thing you need to?
Their palate, make sure you check their palate.
Okay. What else about the breastfeeding experience itself that you need to assess the infant for? Everybody knows what to assess a mom for, but I haven't heard what you assess the infant for.
Is it a premature infant?
Well, the time they're actually swallowing.
Okay.
Are they tolerating it? Are they falling asleep? Is it prolonged?
Very good. But, and I don't know that everybody caught all of that potpourri of things. Latch. Huge. Position is part of latch.
You kept saying baby, I sit here thinking, no, this has more to do with the mom, how she's
Right.
positioning it, how she's holding it. Is
But
the baby
the
part back on the
baby's
nipple?
latch, sucking and swallowing and breathing coordination, those are all part of assessing infant's breastfeeding.
Unless it's another thing for like that's for regular infants. Like if it's a preterm, you want to assess bowel sounds to make sure that they're ready to be taking anything by mouth to assess, prevent. I know what it's called. I just didn't say
Neck.
Sorry. As far as medications,
Yes.
can you tell me medications?
30 meds on your list.
What?
Med list.
For breastfeeding.
Oh.
Breastfeeding.
Yeah, no.
Oh, I thought you meant, what medications do you need to know?
There
The
was a
ones on your
question
list.
on the last exam. I can't remember what it is, but there was a question that was about like opioids and how it depresses breast milk.
Right.
And then but the answer was something else.
That's correct.
And in the book, it said that like a certain medications depress breast milk, but it didn't include all of the medications. So I'm wondering if you could tell me something about all of that.
No.
No at all.
It doesn't.
Doesn't matter.
It's fine.
Opioids depress breast milk, but not all opioids cross into breast milk.
Mm-hmm.
So
And this was part of the lecture.
Yeah.
It was the molecular weight of the medication is what says whether it crosses the breast milk or not.
Methadone. Is it heavyweight? Opioid? I don't even know how you describe that. Whatever.
Molecular weight.
if it's like stronger.
High molecular weight.
No, it's not about strength.
So
It's
we
about,
should know the
it's
molecular
about-
weight.
no, it's about the chemistry and not about the strength and the length of time.
The way I kind of view it is there's little holes.
Yes,
Only certain things can fit through the little holes.
exactly.
So what things go through the holes and what things? Yeah, that's
There's a Bible. It's called Drugs and Mother's Milk,
Don't have that.
No.
and it is this literally this thick, this thick, this thick. And so, who would you call to find out that information? Who has the 911? Give me a break. Who has that book called Medications in Mother's Milk? And I know I wrote Dr. Hale, Hale's name on the board.
Who's Hale?
The one who wrote Medications in Mother's Milk. I know I wrote that on the board.
So I'm gonna call Dr. Hale if I have questions.
No, who are you going to call?
Providers, the lactation consultant, the pharmacist,
The pharmacist.
the
won't
more
know.
experienced nurse.
The lactation consultant is the one with the Bible. That big.
There was another question now. I can't
Dr.
remember
Hale.
this.
Wait, so opioids can go through to the breast milk,
It depends on which opioids.
and it can
What is
decrease mother's
the
milk.
big point about opioids and breastfeeding is what?
Yeah, that depresses.
That's not. No. Has nothing to do with chemistry or molecular weight or anything.
Supply.
So what is the evidence-based practice for intrauterine drug exposure in breastfeeding?
Give them Narcan.
No,
I don't know.
we talked about this.
You can get it through the methadone. You can titrate both the mom
And the baby at the same time, and the risks of infant opioid exposure is much less than the benefits of having the mother and the baby
Withdraw.
stay together and go through the weaning process together, because the mom is also supported in getting off of her opioid habit. And that's, I was telling you about Dr. Cleveland, who's my colleague from the Health Science Center, who has evidence-based practice for this. So keeping them together and using that relationship, very much supported and controlled by healthcare providers during the process is a much better outcome than taking the baby away and the mom going back to the streets and using more and having another baby.
Could you just do a quick review for warm, pink, and sweet? Like, I get the whole concept behind it, but I was just like, if I could just hear your voice into my brain.
Who
that way
wants to put
I hear
your voice into her brain?
somebody, please.
Because I'm
Worrying about the baby warm, pink, sweet.
Mm-hmm.
So when they come out, they're covered in stuff. You want to keep them warm. You dry them off.
Yeah.
Are they pink? It's part of breathing and every circulation.
Acroside, not acroside.
Yeah. And then sweet is their
The blood
glucose. Yeah, their blood glucose. And
are they at risk or not?
yes.
for
But I
that?
get that part. But is there anything else other than that that I can tie into that?
It all works together, and if you've got one thing going off, you're going to have everything going off.
Okay. So just knowing that, like, which I already knew, but like hypoglycemia triggers respiratory distress, so then the baby turns blue, not pink, and then.
Okay. What's the issue with acrocyanosis? Because y'all want to.
It's nothing wrong with it. It can either result with temperature or just a decrease in peripheral blood flow.
Right. So do you have to treat it?
No.
Thank you.
What is the normal time frame for acrocyanosis?
24 hours.
24 hours?
Yes.
I thought I read something about.
I saw 12.
Yeah.
24.
But I will read it.
It's 24 hours.
I believe you.
If I get it wrong, I'm like,
Then it can be a normal
Please.
finding, it's considered a normal finding.
Right.
within the first
You just
24
let them be
hours.
blue for 24 hours.
So,
You don't let them be blue
Not their face or
because
anything,
there's a
it's the
difference
extremities.
between acrocyanosis and central cyanosis.
Just be blue.
I
Just
feel
the
like
hands and feet.
I'm
We just want Smurf
reteaching
hands
the
and
whole
feet.
semester.
Smurf
No.
hands and feet. Pink face, Smurf hands.
Acrocyanosis.
Yep.
For 24 hours. How is it 24 hours?
I need to hear
It just says it's peripheral cyanosis involving just the extremities and is normal during the first day or when the infant is cold. So I feel that could occur anytime.
Mm-hmm.
so there's your answer.
Like, even after 24 hours or,
If the baby is
It's cold.
but if they're born pink and then 12 hours later they become acrocyanotic,
what's the problem?
treat them because they're cold. So you want it thermoregulation.
The first thing you want to do is take the temperature.
Assess.
Not just say it's blue, hands and feet. I want to know the temperature. Because what happens if the temperature goes low?
They hypoglycemia, respiratory
Right,
distress.
everything else. If the baby's warm but just a little bit chilly, then you know that that's all you need to do is warm it up. If it's like 97.3, then you're not going to be warming it up just ordinarily. You're going to be looking at another problem, right? Which is what?
What was the question? Sorry, my brain went.
When the baby's really, temperature's really cold, what do you do? How do you want them?
You
What's-
want to wrap them up, put them under the radiant warmer.
What's the
put 'em
problem
kicker.
if it's low, like 97.3?
There's something going on with infection.
What? Yes. It is not about a fever. If it's low, it's an infection because it's about thermoregulation, not about fever.
Because the mechanism for fevers is not developed in the newborn.
Yeah, their brain is immature.
Super low.
Temperature center.
So instead of going up, showing signs of a fever, severe
It can't.
infection, it's going to drop.
I read that hypoglycemia and impaired thermoregulation are the first signs of neonatal sepsis.
You're right.
Okay, so
I like that.
how do I differentiate that between
Does it
everything
matter?
else that could be going
Does
on?
it matter?
Yes.
What would you do
Assess the temperature.
if you've got a low temperature?
Oh,
And if you've got hypoglycemia, what do you need to do?
Give them
sugar and warm them up, and then see what other symptoms. Assess for other symptoms. I read it.
You're going all over.
Call the
Stop. Something's
provider.
up here.
I'm trying to.
Call
Nah.
911.
Call 911. Be attached to them. L&D.
Okay, if you've got both going on, it's something that you cannot take care of by yourself.
No, I can.
Call this. I don't know.
It's
Call
not within
the-
your scope of practice,
Call the
actually.
NICU.
No,
Right.
there's something
Call the
else going on. I
provider.
promise you.
Yes?
I read it.
Wait, which one was right? The NICU or the provider?
It depends on where the baby is. It all depends upon the
Probably all
situation,
of them.
right?
I need
But
everyone.
provider's going to be the most help and the most immediate.
And a lot of time, well, and a NICU is only available to some of us, right?
Here,
No, I'll go.
probably you call.
You'd have to call whoever's in charge of the nursery or that baby to get a transfer arranged. and that takes a long, long time. But you want the provider on site rather than you babysitting a baby until a baby flight can come in, right? I would rather have a physician provider standing over that baby with me than doing it by myself.
Okay, I figured it out. So if they have hypoglycemia and they have like low temperature or impaired thermoregulation, you're going to want to think infection.
Yes.
So to differentiate that it is infection versus just hypoglycemia and impaired thermoregulation, which could be caused by one another also, you're going to want to assess for other signs of infection to ensure that it's an infection because you can't just rely on the fact that they have low temperature.
Exactly. But you also says not just assess the baby, assess for risk factors, which hopefully you already know.
A lot of invasive procedures, medical equipment. The mom had
Did the mom have a fever? Was the bag of water broken for an extraordinary period of time?
Poor feeding. Well, that's not a risk factor, but
that's
another
a sign.
That's a big sign, though.
Exactly.
Sorry, I figured it out. I just had to, run it through.
Do y'all have any more questions?
No, the more questions and the more we go around and around, the more confused my brain is getting to what I already had in there.
Yes. I'm sorry.
So they're going, no, that's not how I remembered it. La, 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 la.
Well, if we need to take a break, that's fine.
I want to go eat soup.
Go eat food. It's good for you.
Oh my God. It's 2:30.
I know.
Okay. I'll read the whole book tonight and let you know tomorrow.
Okay, but I also want you to, and this is for everyone, review what you've already done. Because you've learned it for an exam and then you've dumped it.
No.
You've learned it for an exam and dumped it.
No.
Learned it for an exam and dumped it.
No.
So what I want you to do is I want you to just review, especially those things that you're a little bit unsure about.
I don't feel unsure. I just feel too sure because there's too much information and I need to know.
How to answer your question.
Exactly. I'm not saying the answer, but like how to get all this information I know and specify it. Because if you really think about it, there's a lot of things that connect.
Exactly.
Like this whole book.
That's what I keep
can
telling
tell you
all.
how this relates to this from chapter 3.
Yes.
And so I'm just trying to figure out how not to go everywhere.
Just don't go off. Take it one question at a time, one situation at a time. There's only
4 right answers.
Maybe.
4 right answers. One's the most
But one's the most right. Okay, we'll see you on Friday morning.